So here you can notice that this is the abscess and it's going to rupture outside. So there is formation of a tract. Clear? And this tract is known as fistula-in-ano. So we are going to discuss in detail fistula-in-ano. Okay, so in this case there is abnormal tract between anorectum and perineal skin. We discussed which theory is responsible for formation of fistula-in-ano, and this is cryptoglandular theory. Okay, we discussed what is the most commonly associated condition with fistula-in-ano, and the most commonly associated condition with fistula-in-ano, and that is anorectal abscess. These are basics. So there is anorectal abscess. This is the most commonly associated condition. Now it's very easy to understand. See, this is anorectum and this is the fistula. Clear? Fistula is of two types. It can be simple fistula or complex fistula. What is simple fistula? Here you can see there is single straight tract. So if there is single straight tract, it is simple fistula, and if there are multiple branched tract, this is known as complex fistula. So first, what is simple fistula? Simple fistula, it's having single straight tract. Simple, single straight tract. Okay. And then there is complex fistula, and the complex fistula is having multiple branched tract. Multiple branched tract. Okay. After that, there is another definition: high-lying fistula and low-lying fistula. So this is in relation to one structure, and that's known as anorectal ring. It is in relation to anorectal ring. This was asked many times in exam in anatomy as well as in surgery. So first you should understand what are the three components of anorectal ring. So you can see here that this is the rectum. Clear? And this is the anal canal. There is anorectal angle, and you know there is a muscle which forms a sling around this anorectum. So what's the name of this muscle which forms a sling? This muscle is attached to pubis. It is attached to pubis and forms a sling around anorectal angle. So this is puborectalis. Name of muscle puborectalis. The second component is internal anal sphincter, and the third component is external anal sphincter. Third component is external anal sphincter. Now see what is the difference between rectum and anal canal. In the rectum, in muscle layer, there is inner circular and outer longitudinal muscle layer. Whenever this is going into anal canal, there is transition. So what happens? The inner circular layer becomes internal anal sphincter and the outer longitudinal layer becomes external anal sphincter. So what are the components of anorectal ring? Here you can see this is puborectalis. This is external anal sphincter and this is internal anal sphincter. Clear? So these are the three components of anorectal ring. This is anorectal ring. And we discussed in anatomy how much is the anorectal angle. This anorectal angle is, the angle is 120 degree. Normal anorectal angle is 120 degree. So this is the anorectal ring. See, if there is fistula and the fistula is having internal opening above anorectal ring, this is high line. And if fistula is having internal opening below anorectal ring, this is low line. So what is high line fistula? Fistula with internal opening above anorectal ring, and fistula which is located, internal opening is located below anorectal ring, that is low line. So another definition, this is high line and this is what? Low line. Okay, so high line fistula and low line. Now see what are the causes of fistula-in-ano. We discussed the most common association is with anorectal abscess. See the other causes. So the most common cause is anorectal abscess. Other causes are patient is having Crohn's disease. So you know, in Crohn's disease patient also there are multiple anal fistula. In lymphogranuloma venereum also there is fistula. Actinomycosis, foreign body in rectum, malignancy, HIV, these are the other causes. So in all these cases you may find fistula. There is a classification system in relation to Fistula-in-Ano, and what's the name of that classification? It is the Parkes classification. So according to Parkes classification, there are 4 types of Fistula-in-Ano. See the types. Now in this picture you can see this is the internal anal sphincter and this is external anal sphincter. So here you can see the tract is mainly passing between these 2 sphincters. So what's the name? Type 1 is known as intersphincteric. Type 1 is known as intersphincteric. Clear? Now see, type 2. Here it is going to cross both of the sphincters. So type 2 is, it is transsphincteric. Clear? Now here you can see, this is the tract. So this is type 3 and type 3 is suprasphincteric. And you can see it is extrasphincteric, type 4. So type 4 is extrasphincteric. Okay, we discussed many times that generally in surgery, if the classification starts from 1, 2, 3, 4, 5, what is the most common type? Type 1. And if it starts from A, B, C, D, E, what is the most common type? Type A. So here, what is the most common type? It's the type 1. So the most common type is type 1. So how to remember? The mnemonic is it's extra. The mnemonic is it's extra. 1, 2, 3, 4. So what is 1? I means intersphincteric, T means transsphincteric, S means suprasphincteric, extra means extrasphincteric. So these are the 4 types. Now see the presentation. Generally Fistula-in-Ano is more common in males and usually it is seen in 3rd to 5th decade. What is the presentation? These patients are coming to you and they tell you that, sir, I'm having external opening in the perianal region. So in the perianal region there is one external opening. What else they are going to tell you? That, sir, there is periodic seropurulent discharge. Means every 2 to 3 weeks sometimes there is serous discharge or seropurulent discharge. He will also give you the history that once there was infection leading to abscess. So if the tract is blocked or obstructed, infection can lead to abscess formation. And special feature, see, this is the rectum and this is the anal canal. Sometimes the internal opening is located in the rectum. And if internal opening is located in the rectum, there will be one special history given by the patient. This patient will tell you that, sir, I pass feces and flatus from that external opening. So whenever patient gives this history that patient passes feces and flatus from external opening, you should understand that the internal opening is in the rectum. Why? Rectum is the fecal reservoir. Clear? So if patient passes feces and flatus, it means the internal opening is in the rectum. In anal canal, fecal matter is not there. Whenever patient is going for defecation, then only fecal matter comes. Okay, so these are the special points. First, see the clinical features. It is more common in males and generally it is seen in 3rd to 5th decade. What is the presentation? Here you can see these patients have external opening in the perineal region, and from this external opening there is seropurulent discharge. Seropurulent discharge, right? Sometimes there is obstruction of the tract, and if there is infection, it can also lead to abscess. And if patient passes feces and flatus, passage of feces and flatus from the external opening suggest what? That internal opening is in the rectum. It suggests that internal opening is in the rectum. Now see, in patients of Fistula-in-Ano, what we are supposed to assess? So here, first we have to assess that what is the location of external opening and how many external openings are there. Second, where is the internal opening? What is the course of tract? Whether any secondary extension is there or not, and what is the complicated disease with which patient is suffering. So we perform examination and we go for investigations to assess these key points. So what are those key points which should be assessed in patients of Fistula-in-Ano? The key points which should be assessed in patient of Fistula-in-Ano. First, the location of internal opening. Location of internal opening. Second, location of external opening. What is the course of tract? Whether there are secondary extensions or not. So presence of secondary extensions. And complicating disease. Patient is suffering from any complicating disease. Okay. So after history, we have to perform the examination. So on inspection, you are going to see that external opening. We are supposed to perform the digital rectal examination. Now see, whenever we are going to perform the digital rectal examination, what you are going to feel around this internal opening, there is induration. So you can feel the induration around the internal opening. Sometimes beginners are not able to appreciate this induration. So what? You must be knowing what is the length of proctoscope, 10 centimeter. So if this internal opening is within 10 centimeter, you can perform the proctoscopy and you can visualize. Clear? So how we can localize this internal opening? We can localize this on digital rectal examination as well as proctoscopy. Clear? On digital rectal examination, there is induration and the length of proctoscope is 10 centimeter. So we can visualize the 10 centimeter if internal opening is there and we can localize it, right? But I told you that beginners are not able to appreciate the internal opening. So that's why Goodsall's made the rule. And according to this rule, on the basis of external opening, we can easily localize the internal opening. So Goodsall's rule is used to indicate the likely position of internal opening on the basis of external opening. Okay, so see what is the Goodsall's rule. Now imagine that this is the anus and I'm going to divide this by an imaginary transverse line. So here you can see this is the anterior part and this is the posterior part. Clear? So anus is divided by an imaginary transverse line. It is said that anteriorly located external openings are joined by short straight tract. Can you see here? Short straight tract. And the posteriorly located external openings are joined by long curved tract. Long curved tract. Clear? And generally posteriorly located external openings are joined by long curved tract and it's going to open where? In the posterior midline. So at which o'clock position? 6 o'clock position. Now see, here this is the anteriorly located external opening. What is the location? It is located at 1 o'clock position. So if you see, the internal opening is also located at 1 o'clock position. Here it is located at 11 o'clock position. So here you can see the internal opening is also located at 11 o'clock position. Now here you see it is located at 8 o'clock position. Since it is posterior, here you see the internal opening is at 6 o'clock position. So I'm repeating, according to Goodsall's rule, anteriorly located external openings are joined by short straight tract. Posteriorly located external openings are joined by long curved tract and it is going to open posteriorly in the midline. So the name of this rule is Goodsall's. This is Goodsall's rule. Clear? So question is expected that examiner is going to tell you that the location of external opening is at 4 o'clock. It's 4 o'clock. Clear? So if location is at 4 o'clock position, what is the location of internal opening? Yes. So if it is 4 o'clock here, obviously it's posterior. So internal opening at 6 o'clock position. If the external opening is located at 10 o'clock position, internal opening is also located at 10 o'clock position. But there are exceptions. So what are the exceptions? You can see the conditions in which this external opening is located more than 3 centimeter from anal verge. If external opening is located more than 3 centimeter from anal verge, or the cases in which there are multiple external openings, posterior rule will be applied. It means the internal opening will be at 6 o'clock position. See, so what are the exceptions of Goodsall's rule? Exceptions. So first, external opening located more than 3 centimeter from anal verge. Clear? And second, if patient is having multiple external openings, so if there are multiple external openings, okay, so these are exceptions. It means in both of these cases posterior rule will be applied. So where is the internal opening? It is posteriorly in the midline and it is 6 o'clock. It is at 6 o'clock position. So this is Goodsall's rule. By the way, there are two questions which are asked. What is the first investigation done in patients of fistula? So in that fistula tract, we inject the dye and take X-ray. This is fistulogram. But there is a better investigation which is having very high sensitivity. It can detect all the tracts and the investigation of choice is MRI. So how we are going to make the diagnosis? First investigation done in Fistula-in-Ano, and that's fistulogram. Fistula-in-Ano, inject the dye, take X-ray, fistulogram. And what is the investigation of choice for diagnosis? Here it's the MRI. Now see how we are going to manage these patients. Imagine this is the patient and this is the fistula, okay, fistula tract. What we are going to do, if we are giving incision over the fistula tract and you give incision over the fistula tract and you are going to open the tract, this is known as otomy. So what is this? Fistulotomy. And in second situation, suppose this is the fistula tract and you are going to excise the fistula tract. Can you see? I'm going to excise this is the tract and I'm going to excise the fistula tract. So this is fistulectomy. So fistulotomy and fistulectomy. Generally, these are not done nowadays because of increased morbidity. Clear? So what? Fistulotomy and fistulectomy. So the treatment options. What are the treatment options? Clear? First is fistulotomy. Second is fistulectomy. So fistulotomy, fistulectomy, we are not doing these commonly because of increased morbidity. Nowadays there is a popular treatment available and that's known as Ceton. In the market it is available by the name of Charsutra. Ceton we will discuss in detail. Ceton. Fourth is WAFT. What is the full form of WAFT? This is video assisted anal fistula treatment. Full form, video assisted anal fistula treatment. Here with the help of miniature endoscope, what we do, we treat it. So that's why it's known as video assisted anal fistula treatment. And we can inject the glue inside the tract. So these are the treatment options. The most popular is this Ceton. Clear? What are the types of Ceton which are available? What is this Ceton? Ceton is a thread which can be made of silk, linen, elastic, or it could be a rubber band also. What are the types? It is of 4 types. First, cutting Ceton. Second, non-cutting Ceton. The other name of non-cutting Ceton is draining Ceton. It's draining Ceton. There is marking Ceton, and there is staging Ceton. Okay, how we insert the Ceton, how it looks like and how it works, see. So in this picture, can you see, we used a rubber band as a Ceton for the fistula. So see the diagrammatic representation. This is the fistula, and I inserted this yellow colored rubber band like this, and I took out both ends like this, and then I'm going to tie the knot. So here you can see this is the final appearance, and I'm going to tie a knot. See, whenever this ceton is loosely applied, if it's loosely applied, whatever the pus collection is there, this pus collection is coming out. So it acts as a drain. And whatever the pus collection is there, infection is there, it is easy for the pus to be drained out. So it is also known as draining ceton. So non-cutting ceton or draining ceton when it is used or it is applied loosely. And what is the problem? Every week, suppose I'm going to tight the ceton every week, so it will start cutting the soft tissue. So if you start tightening it, it will start cutting the soft tissue, and after some point of time, it reaches this place. So this is known as cutting ceton. What is the advantage of cutting ceton? If a patient is having high-lying fistula and you are using cutting ceton, it is going to convert that high-lying fistula into low-lying fistula. What's the main problem with high-lying fistula? Since high-lying fistula is located above anorectal ring, anorectal ring is having important role in defecation. So if any structure is injured here, it leads to incontinence. So that's why for high-lying fistula, we go for cutting ceton. It converts high-lying fistula into low-lying fistula. And the patients who are having multiple infected fistula, like HIV positive patient, Crohn's disease patients, in those cases we are using draining ceton to control the infection. Clear? So what are the uses? We discussed the uses. Cutting ceton. So it is used to converts high-lying fistula into low-lying fistula. Okay, and what's the use of this draining ceton? Draining ceton, it is used in patients who are having infected fistula, multiple infected fistula like Crohn's disease and HIV positive. So these patients have multiple infected fistula, and this is used to control the infection, to drain the abscess or pus collection. So this is how we manage the patients of Fistula-in-Ano.